ISA Nanded and Platinum Jubilee of ISA National. So hats off you all and your team. This is my second presentation for Nanded ISA. First, it was at Misakon Nanded. The My debate was on spinal induced hypotension, mephenterine versus phenylephrine. That was a great debate, and I remember Dr. Patange had done the successful Misakon. Someshwar, are you there?
Join होतील सर सरांना बोललोय just.
Okay. Someshwar and Jakir, then Rajesh and Dr. Chavan, all members I remember, they done the wonderful job during the Misakon at Nanded. Thank you. Now let us move to today's topic, that is CPR in pregnant patient, that is in obstetric patient. I will share my slide. Is it visible to everybody? Sachin?
Yes, sir. Yes.
Because in this presentation, you all of you, nobody will see the full screen because there is a problem in this this Google Meet and the Zoom Meet. So now I will continue.
Yes, sir.
I know every one of us knows very well about the CPR as we are anesthesiologists, but it is not true with the other clinicians. CPR The maternal collapse is defined as an acute event involving the cardiorespiratory and cerebrovascular system, resulting in the or absent consciousness level at any stage in the pregnancy and up to the 6 weeks after delivery. That is up to 42 days. This maternal collapse incidence is 1 in 20,000 to 1 into 30,000 pregnancies in United States. The mortality rate is 13.95, that means 14 days per 1 lakh in developing nations. And globally, 800 maternal deaths occur daily. Out of the 5,29,000 maternal deaths globally, 1,36,000 deaths, that is 20% of the all deaths, are from India each year. However, the maternal mortality rate are just a small representation of the maternal critical event. Maternal near miss data should be considered, and the near miss data is not available, and the maternal morbidity data is not available. The near miss is defined as a woman who nearly died but survived a complication that occurred during pregnancy, childbirth, or within 42 days of termination of the pregnancy. In the Netherlands, the maternal near miss incidence is 1 as to 141 deliveries. So, caregiver, all of us must have a thorough understanding of maternal mortality to prevent and to treat the cardiac arrest in pregnancy. Before going to topic, I would like to present some cases. These are the 4 cases. First case, I was there, or I witnessed this case, and there was a call for help for me. The second and third case, I was a anesthesiologist there, and fourth case is from the literature. Case was, it is almost 20 years back, a primary full-term अनफॉर्च्युनेट टाइम मुहूर्त दॅट मीन्स आपल्याकडे आता ते मुहूर्ताचं प्रमाण खूपच आहे. मुहूर्तावर डिलिव्हरी, मुहूर्तावर सीझर आणि त्याप्रमाणे दॅट वॉज अ फॉर्च्युनेट that is Muhurta plans LACS and the anesthesiologist call is given when patient admitted in the night. The anesthesiologist was busy in the morning and however he managed to come uh, there and at that time everything was ready. That surgeon is holding the spinal needle and so the anesthesiologist due to the muhurt or to manage the time he gave the spinal anesthesia. Baby delivered but mother collapsed. There was a severe hypotension. Patient he could not manage the hypotension with at that time only mephentermine was available with IV fluids and uh, he called for help. But before that, the patient was there was a complete arrest and we could not survive the mother, but we saved the child. In this um, patient there was not history was not proper taken or history proper was not given by the relative. He had valvular heart disease, severe valvular heart disease, and due to social acceptance, that is the girl's marriage was not was the problem due to this heart disease. So they have not given any history. The second case, previous full term normal delivery, polyhydramnios, history of bronchial asthma, induction of labor was done, and there is a spontaneous rupture of membrane. We after the spontaneous rupture of membrane, patient presented with severe breathlessness, hypotension in the ward, and then patient shifted to the labor room. But at the same time, there was LACS was going on in the OT, obstetrician and other staff was engaged in the theater. Uh, so patient was decision was taken to shift the patient to ICU. Here, patient collapsed. There was a severe hypotension. We given the bronchodilator, steroid, but breathlessness was there. So we then come to diagnosis of amniotic fluid embolism, but gynecologist not ready to accept or treat the high risk patient there, and patient relatives were also not ready to do the LACS. So in this patient there is misleading history first that there was a bronchial asthma and there was inadequate infrastructure and not accepting to treat the high risk patient, and patient died in the transport. Case 3 PIH with thrombocytopenia, platelet count 1 lakh, all the investigation were normal, BP was 140/90. But due to, as we anticipated, high risk patient, patient was shifted to ICU and we the case was LACS was done in the ICU backup hospital. The LACS was uneventful, so shifted patient was shifted to ICU. But after 2 hours, there was a severe breathlessness. Patient was agitated. SpO2 was decreasing. So patient shifted to medical ICU. Patient collapsed. Patient was intubated. CPR given. When patient kept on ventilator, defibrillation done, but patient was not survived. In this patient, even identifying the high risk patient, taking proper care, we could not save the patient because there was a amniotic fluid embolism and it is refractory to the treatment. For case, here there patient was a history of chronic hypertension, 34 weeks, came with high blood pressure, 180, 200. There was tachycardia, After 30 minutes, patient was cyanotic, agitated, sitting on the edge of the bed. After that, patient had a cardiac arrest. The CPR was given. After 5 minutes, there was no response. Obstetrician called for emergency cesarean section. Patient transferred to operating room. After 12 minutes of arrest, delivery of two live infants were there. In this case, you see the even the CPR was given. It was the uterus was not displaced from um, not displaced or left lateral uterine displacement was not given LUD from. So there was a compression of inferior vena cava, particularly in the presence of twins. In addition, after CPR of 4 minutes, no attempts were made to deliver the infant, both for maternal and fetal benefit. When the decision was of delivery or cesarean section is made, the patient was moved to the operating room, resulting in the additional delay in the time of the delivery. So there was a lack of knowledge among the providers regarding the safety and safety of the patient. Patient had several risk factors of pulmonary edema, and on presentation to the emergency department, her findings were suggestive of early onset of failure. So early detection and prompt management of potential causes of CRA during pregnancy are extremely critical. So how to reduce this mortality? Almost 30% of cardiac deaths are preventable in pregnant patients because most of them are young. And so why there is a mortality? Several studies have reported that most of the physicians that may respond to perform CPR in pregnancy lack the knowledge, necessary knowledge and skill. Why there is an increase in mortality and why there is a high risk patient? Because increasingly women who have risk factor for heart disease are becoming pregnant. They are older, might have diabetes, high blood pressure, obesity, high cholesterol. A woman with more chronic health problems such as chronic kidney diseases, seizure disorder, lung diseases are entering into the pregnancy than the previous so many decades. It may not be the disease that put the mother at the risk, but rather the inadequate treatment of the underlying health problem, and people are afraid to treat them because they are pregnant. That we have seen in the last case. On the top of existing health problem, there are potential pregnancy complications such as preeclampsia, gestational diabetes, which can make already risky situation worse. The most common causes of maternal cardiac arrest are bleeding, that is PPH, heart failure, and amniotic fluid embolism. So every patient having high risk or complex issue, chronic health problem, who become pregnant should ideally receive a care at the center that specialize in high risk pregnancy. Before going to the CPR, what we all need to know. We should know the causes of cardiac arrest, anatomical and physiological changes in pregnancy related to resuscitation, management of unstable pregnant patient in hospital, modification for resuscitation in pregnancy. Then we should know how to perform perimortem cesarean section, how to treat the cause that lead to the cardiac arrest, and how to take care of the post-arrest patient. Then we should do the assessment of fetus and newborn. All these topics will be covered in my this lecture. Cardiac arrest causes. This can be classified as A, B, C, D, E, F, G, H, like that. That is anesthetic complication like high spinal anesthesia or drug toxicity, then accident, trauma, bleeding, DIC, placental ablation, placenta previa. C for cardiac diseases, commonly cardiomyopathy, valvular heart disease, drug anesthesia, anaphylactic embolism. It may be thromboembolic, pulmonary embolism, or amniotic fluid embolism, ectopic pregnancy, fever, GIT symptoms. Then you know the 5HT and 5H of this hypovolemia, toxins, and thromboembolism is common in pregnancy. You can also can classify it as a unknown incidence, abrupt and unpredictable massive pulmonary or amniotic fluid embolism. Then here the once it is abrupt and the it is unpredictable, gradual and expected like hypovolemia or septic shock. Then you can also classify it as cardiac, non-cardiac. You can see in this table, cardiovascular diseases are the main or most common cause of the cardiac arrest in the pregnancy. Before going to the CPR, we should know the anatomical and physiological changes during pregnancy, because the management or modification of the resuscitation or medication changes are related to these anatomical and physiological changes. Cardiovascular changes, uteroplacental, maternal blood flow, arterial blood flow, pressure increases. There is decrease in systemic vascular resistance. Cardiac output increases by 30 to 45%. Heart rate increases 10 to 15 by 10 to 15 beats per minute. Most important in supine pregnant patient due to gravid uterine pressure, compression of IVC decreases venous return and decreases cardiac output by 10 to 30%. So, poor venous flow compromises the infradiaphragmatic IV side. So, you should not take femoral or saphenous route to in the pregnant patient, but you should take the upper extremity veins. Respiratory system increased tidal volume due to progesterone and other hormones like progesterone, estrogen. There is rapid decrease in the functional residual capacity. The decreased arterial oxygen content by 20% in pregnant patient. Oxygen consumption increases because of the demand of the fetus and maternal metabolic process reaching a level of 20 to 33%. The reduced functional residual capacity reservoir and increased consumption of oxygen are the responsible for the rapid development of hypoxemia in response to hypoventilation, and with hypotension there is a cardiac arrest. The oxyhemoglobin curve is shifted to the right. The higher partial pressure of the oxygen is required to achieve the same maternal oxygen saturation. There is upper way airway demand variability that due to hormonal effect, and it may lead to visualization difficult during laryngoscopy, and there is increased chances of the bleeding. Then there is decreased tolerance of hypoxia, tongue mucosa, supraglottic edema is there, fragility, difficulty. So there is a difficulty of mask ventilation, the low FRC, elevated diaphragm, rise intra-abdominal pressure, Mulampatti class 3 airway is there, and due to weight gain and obesity, the airway management is very difficult. Gravid uterus make rise and fall of the chest difficult to evaluate during the ventilation, and due to large breast in obese patient compression, there may be difficulty in compression, defibrillation also. Progesterone relaxes gastroesophageal reflex, so uh, there is a prolonged transient time throughout the intestinal tract during the second and third trimester. Due to esophageal sphincter relaxation, it causes, there are chances of aspiration of the stomach content. Then there is a narrowing of the oncotic pressure, wedge pressure gradient that increasing the tendency for pulmonary edema to develop. Drug metabolism is altered by several different mechanisms in the pregnancy. Before going to the treatment of the CPR, we how to manage the unstable pregnant patient in the hospital. That is high risk patient. We know the high risk patient is admitted, and CMA goes in, no, CMA collapse. So this patient can be managed by full lateral left lateral decubitus position to relieve the aortocaval compression. Administer 100% oxygen by face mask. Assess intravenous IV line above the diaphragm, and you should investigate and treat the precipitating factors. If the cause is if there is hypolemia, give crystalloid and colloids. If there is a hemorrhage, give blood like this. This is the obstetric early warning sign. The obstetric early warning sign is to discriminate between the survivors and non-survivors among the critically ill patient is suggested by Carl et al. These signs are like temperature, pulse, respiratory rate, systolic blood pressure, level of consciousness, and supplementary oxygen required to maintain the oxygen saturation above 95%. These are monitored and score are given to these parameters. If there is the score is 0 to 1, repeat the observation. If it is 2, repeat after 30 minutes. If it is more than 3, call the concerned doctor immediately. That patient may collapse in next few minutes. Then, if uh, this score is also used to evaluate the severe maternal outcome of the woman having abnormal either lower or higher than the normal. We are more likely to have severe maternal outcome than normal patient, and these patients should be shifted to ICU with oxygen, IV line, and left lateral treatment. These monitors can be documented with chart like this with time and date. So now CPR, cardiopulmonary resuscitation, is a series of steps used to establish artificial ventilation and circulation in the patient who is not breathing and has no pulse. Everybody knows it. So what are the goals of the CPR in pregnant women? To understand and perform basic and advanced life support in pregnant patient, to understand the adaptation of the CPR, understand the importance of early defibrillation when appropriate, and to understand the need to perform perimortem cesarean section, that is PCMD. Many CPR resuscitation parameters are the same. Standard adulteration guidelines are same, only addition of left uterine displacement are applicable to the pregnant woman. Compression rate, depth, hand placement, backboard, minimal interruption are common with non-pregnant patient. So how we differentiate the non-pregnant patient and pregnant patient resuscitation profile? In non-pregnant patient, there is a one life, that is one person is affected. In pregnant patient, mother and fetus both are affected. In non-pregnant patient, chest compression is same, in non-pregnant and pregnant patient, airway is also same. Only nasopharyngeal airway should not be used because there is a mucosal edema and there are chances of bleeding. ETD should be used 1 mm smaller in size. That if you are using 7 mm routinely to the pregnant patient, use 6. Intubation may be difficult in this patient. We have seen already the anatomical changes. Early intubation by expert, that is trained anesthesiologist or senior anesthesiologist, is recommended. Breathing, a single person can ventilate with a bag and mask in non-pregnant women, but in pregnant patient, you may need 2 person or two-hand bag mask ventilation as airway resistance is more. Pregnant patient is more prone to hypoxia than non-pregnant patient, so oxygenation is more important than the risk of aspiration. Defibrillation, same biphasic one defibrillator can be used, or AED with 120 to 200 joules. And in pregnant patient, defibrillation is safe. IV is accessed preferably upper extremity in non-pregnant also, but you can use uh, lower extremity. But in pregnant patient, above the IV access should be above the level of diaphragm. Then special measures, ECMO, UHG, then ECO, you can use during resuscitation in non-pregnant and pregnant patient. CPR, you may come into a scenario that is, these are there may be 4 scenario where you may go for resuscitation. One is out of hospital as a first business, that is you don't have any emergency equipment with you, or out of hospital as a emergency medical services, that is you may be a part of the emergency medical service team. In hospital, in hospital basic life support, and in hospital advanced cardiac life support. The two most important interval affecting the patient survival are the collapse to first CPR attempt interval and collapse to the first defibrillatory shock interval. This is the cardiac arrest in the pregnancy out of hospital basic life support algorithm. That is uh, safe approach. Then unresponsive, shout or call for help. Dial 118, or then open the airway with chin lift, head tilt, and jaw thrust. If patient is not breathing normally, give 30 chest compression and 2 rescue breaths, and wait for the advanced life support. For adult with cardiac arrest compression only, that is hands only CPR, which involves chest compression without artificial ventilation, is recommended as the method of choice for the untrained rescuer or those who are not proficient, as it is easier to perform. When the cardiac arrest occur out of the hospital, will likely have worse outcome than the cardiac arrest that occurs in the hospital. If the resources are available, emergency response team to the maternal cardiac arrest should include appropriate complement of staff to ensure that BLS and ACLS action can be performed. Minimum 4 EMS providers or staff should be there. If available, the transport of the out of hospital collapse patient should be directed towards a center that is prepared to perform PMCD, but transport should not be prolonged by more than 10 minutes. to reach the center, and that center should also available neonatal care unit. This is the cardiac arrest in pregnancy out of hospital basic life support algorithm for healthcare providers. When EMS call is received, patient is identified as a pregnant patient, then document the time. If patient is unresponsive, patient is pregnant, no breathing or no normal breathing is there, get AED or ask for the AED available to do so. Check the pulse. If there is a definite pulse, give one breath every 5 to 6 seconds. Recheck the pulse every 2 minutes. If there is no pulse, begin cycles of 30 compression and 2 breaths. Apply AED if it arrives. If rhythm is shockable, give one shock. Resume CPR immediately for 2 minutes. If it is not shockable, resume CPR immediately for 2 minutes. Check the rhythm every 2 minutes if not shockable. Then how to manage the cardiac arrest in hospital? It is the in hospital, the nurses are often the first responders in the cardiopulmonary arrest. They give the first call. However, any hospital staff member may witness or discover a patient in arrest should be able to begin basic emergency care or basic life support. Start basic life support, call for help. A maternal cardiac arrest emergency should be declared. The emergency team consists of physician, obstetrician, then neonatologist, and anesthesiologist. Start high quality chest compression immediately to optimize the maternal and fetal outcome. A defibrillator or AED should be connected to the patient. A clear airway must be established with simple airway maneuvers such as heel tilt, chin lift, and jaw thrust. Ventilation with bag and mask should be started. All of these procedures should be performed with pregnant woman placed in the lateral tilted position or supine with left uterine displacement. It can be achieved manually. So simultaneous CABU, that is chest compression C, then current, that is defibrillator, A for airway, B for breathing and uterine displacement. Instead of CAB in pregnant patient, you should remember CABU. U is uterine displacement. Displacement is manual is important in resuscitation. This is same in the basic life support algorithm. Now we'll see what are the factors affecting the chest compression in the pregnant patient. Aortocable compression. The pregnant patient supine position will result in aortocable compression. The relief of compression must be maintained continuously during resuscitation. In this figure, you can see the compression, aortocable compression. So, what defines the gravid uterus with the potential to cause aortocable compression? The determinants are the uterine weight, and that uterine weight include weight of the fetus, and the weight of fetus may increase if the number of fetuses are there. Then the weight of the fluid, that is polyhydramnios, then it will increase the weight of the uterus. So the compression, aortocable compression will be more. Other factors that may affect the degree of aortocable compression include the size of the fetus, the relationships of the fetus, that means presentation of the baby, and increased body mass and morbidly obese patient increases the aortocable compression. This is the left uterine displacement, how you can do. You can do left uterine displacement with single hand, two hand, or with the um, backboard, or with the tilt of the table. Mm, with one hand, you should push the uterus upward and to the left. If you are using a single, you are at the right side. If you are on the left side of the patient, you can pull the uterus upward and towards you. This is the manual method of LUD. You can put a wooden wedge under the groin, or usually in our setup in limited resources, we put a 1 liter saline bottle uh, to give the LUD or to relieve the compression. It can we are using it for the laparoscopic appendicectomy and laparoscopic cholecystectomy. And 1.5 to 2 inches shift is sufficient. So there is a no difference in the 15-degree or 30-degree LUD. 15-degree LUD is also sufficient, and manual is preferred than the tilt, because when you are giving the tilt to the table or with the back board, the resuscitation is difficult. Not only chest compression, but airway management and defibrillation is difficult with the uh, tilt. So manual LUD is preferred. LUD increases at 20 weeks 8% of the ejection fraction and 20% stroke volume. At 32 weeks, the LUD, that left uterine displacement, increases 27% of the ejection fraction and 35% of the stroke volume. So it is important. Chest compression, use backboard during cardiopulmonary resuscitation is important, because most of the um beds in the wards are, or mattresses are spring-like action, or they may be air-filled, or water beds are there. So the air-filled or water-filled beds should be deflated. Then high quality chest compression, we should give high quality chest compression. High quality chest compression means it is recommended in AHA 2015 guidelines. Chest compression should be performed at the rate of at least 100 per minute and not more than 120 per minute. And the depth should be at least 5 centimeter and should not be more than 6 centimeter, and it should allow full recoil before the nest compression with minimal interpretation, and compression ventilation ratio should of 30 to 2 should be maintained. Interruption should be minimized and limited to 10 seconds except for specific interventions such as insertion of an advanced airway or intubation. Position of the hand during chest compression are the same, that rescuer should place the heel of the one hand on the center of the victim chest, and the other and the heel of the other hand on the top of the purse, so that hands overlap and are parallel. There is no specific event to support changing the recommendation for the hand placement of the chest for chest compression in pregnant patient. Compression, remember, compression are the key to better outcome in resuscitation of the pregnant woman and other victims also. So compression is the key. Hypoxia rapidly develops in pregnant patients. We have seen the airway, anatomical and physiological changes. So patient develop hypoxemia early. So rapid and high quality CPR is required. The first responder with minimal airway experience, bag mask ventilation with 100% oxygen is the most rapid non-invasive strategy to initiate the ventilation. That is before into trying to intubate the patient. Intubation is difficult. Bag and mask ventilation with one hand or two hand should be initiated. The standard initial compression ventilation ratio is 30:2. Hyperventilation has been shown to decrease the likelihood of survival because many times in hurry we hyperventilate the patient. So it should be avoided, and it also interrupts the compression. Two-hand bag mask ventilation is more effective, and modern airway like LMA and IGL, these can be used for as a airway. The same current deep now we will see defibrillation. There is no modification of the recommendation for application of the electric shock during pregnancy. It is safe also. Patient should be defibrillated with the shock energy of 120 to 200 joules with subsequent escalation of the energy output if the first shock is not effective. So we were using biphasic than the monophasic. Compression should be resumed immediately for the in-hospital setting where staff have no ECG rhythm recognition skill and defibrillation. The AED, that is automated external defibrillator, may be considered, and that these are uh, these can be used easily. However, anterolateral defibrillator pad replacement is recommended as a reasonable default. The lateral pad should be placed under the breast tissue. This is the only change or important consideration in the pregnant patient. Shock from a defibrillator and chest compression will not harm the fetus because the fetus will likely not survive if the mother does not receive the life-saving measures. This is the defibrillator AED. Turn on the device. It automatically sends all, give the audio instruction. Second, expose the patient chest. Apply the electrode shown in the figure. Allow the aid to analyze the person's heart rhythm. Make sure no touches to the person. Continue hands only CPR after the shock. We have seen the basic life support and in advanced life support. Ask the expert help immediately for advanced cardiac life support. There should be a call to action that activate the maternal cardiac arrest team, that is maternal blue code, that ensure the specialized equipment is brought to the scene without delay, and you should continue the basic life support. You should treat and rule out the cause of the arrest. Decide cesarean section if needed. Put in left lateral position. Then good ventilation with bag and mask. IV fluids to correct the hypotension. Chest compression are done. Then use AED if indicated. Endotracheal intubation should be done early and by the expert because upper airway narrowing is there. Manage all reversible causes as they present. If there is no response to resuscitation, plan emergency cesarean section. Every hospital must have specified method to activate the maternal cardiac arrest team. For example, maternal code blue or code blue matter. It should be it consists of the adult resuscitation team, that is physician with nurse, obstetrician with obstetrician nurse, then anesthesiologist and um, anesthesia assistant. Then fourth is neonatal team, one nurse, then one neonatal physician and one neonatal respiratory therapist. This compromise a cardiac arrest multimodal approach team, and this team should arrive at the scene when the maternal code blue is activated. Special equipment for these, the maternal maternal cardiac arrest, PCMD should be ready in the hospital for cesarean section. Even only one scalpel, one scalpel is sufficient for PCMD. But you can make a PCMD tray with forceps and all other required material. Then airway management tray with routine airway and advanced airways. Then the neonatal resuscitation tray with airway, then laryngoscope and all other things. So these tray and this equipment should be ready in the obstetric room. This is the BLS ACLS. BLS team action ongoing high quality CPR defibrillation, monitor CPR quality. Maternal arrest team arrives, then considered etiology of the cardiac arrest. Then what are the maternal intervention? Appropriate airway management should be done. Then IV fluid above the diaphragm, give typical ACLS drugs and dosage. If patient receiving IV magnesium, stop the magnesium and give IV calcium gluconate. If obstetric intervention is required, give continuous manual LUD, remove or detach fetal monitor, prepare for the emergency PCMD. This is we have already discussed. ETT should be started with 6 to 7. Then supra airway replacement is preferred for rescue tragedy for failed intubation. Then if prolonged intubation attempt should be avoided to prevent the deoxygenation and this prolonged intubation attempt hampers the chest compression and there may be a trauma bleeding. If required pressure is not routinely recommended in CPR in pregnant patient. Continuous waveform capnography, in addition to the clinical assessment, is recommended as the most reliable method of confirming and monitoring the correct placement of ETT. If there is a failed intubation or you cannot intubate, cannot ventilate, then surgical intervention like cricothyroidotomy can be done. Recent advances in CPR, there you can give direct cardiac massage with open chest, or if the abdomen is open for cesarean section, then you can massage directly. Cardiac massage can be given transabdominally. Then use of UHG and echo and transesophageal cardiography. This will facilitate or use for diagnosis of the cause of the arrest, and it also give you the idea about the your CPR, if CPR is properly going on. ECPR, extracorporeal CPR, extracorporeal CPR like ECMO. ECMO is it can be beneficial in pregnancy also. 60% of the maternal and 70% fetal survivor is recorded in the ECMO used for the resuscitation. And then extracorporeal lung assistant, extracorporeal CO2 removal, these modern extracorporeal resuscitation ECPR methods are under investigation. Arrhythmia specific therapy, refractory shock ventilator, the drug recommended are if the shock is refractory, if the arrhythmias are shock resistant, then ventricular fibrillation and tachycardia, amiodarone can be infused and it should be administered with 150 milligram doses repeatedly as needed. In the setting of cardiac arrest, no medication should be withheld because of the concern about the fetal tetralogy, because importance is given to the mother. Physiological changes in pregnancy may affect the pharmacology of medication, but there is no scientific evidence to guide a change in current recommendation. So, usual doses of drugs and are recommended during ACLS. Beta blocker can be used as first line therapy for arrhythmia. It is safe in pregnancy. Metoprolol can be preferred long QT interval where beta blocker were found effective. In general, for recurrent primary ventricular tachycardia and ventricular fibrillation, amiodarone should be considered. Evaluation of the reversible causes of cardiac arrhythmia should be routine, and thyroid dysfunction and adverse drugs effect, electrolyte disturbances, cardiac ischemia, heart failure should all be identified and corrected when possible. Other drugs used during ACLS, 14-unit IV or intraosseous vasopressin is an alternative to the first or second dose of epinephrine. Administering 1 milligram epinephrine IV or intraosseous every 30 to 5 minutes. In the randomized study of patients with in-hospital cardiac arrest, demonstrated that the combination of vasopressin, epinephrine, and methylprednisolone during CPR and stress dose of hydrocortisone in post-resuscitation shock lead to improved survival to the hospital discharge. Vasopressin can induce uterine contraction, and both agents are considered equivalent. Now we'll go to the specific treatment of the cause myocardial infarction, PAMI. That is, if there is a myocardial infarction, the coronal intervention is preferred than the fibrinolytic drug. The primary angioplasty in myocardial infarction is preferred than the fibrinolytic drug. If there is a amniotic fluid embolism, this topic was already discussed in last lecture. Just I want to add AOK treatment. AOK is atropine, ondansetron, and ketorolac. Atropine 0.2 milligram, ondansetron 8 milligram, and ketorolac 50 milligram. This cocktail is suppose this is beneficial in the amniotic fluid embolism patient, and this study is under trial, and this improves the patients. They have seen that there is a increase in the oxygen saturation and survival rate of the patient of the amniotic fluid embolism. Massive thromboembolism, thrombolysis, or you can do the embolectomy. If local anesthetic induced cardiac arrest is suspected, give 20% of lipid emulsion, that is intralipid, 1.5 ml per kg per minute, and then 0.25 ml per kg. Calcium for magnesium, 10 ml of 10% calcium. Calcium, you can use calcium chloride or calcium gluconate also. Soda bicarb is not routinely recommended, but if there is a pH is less than 7 or there is a base excess of more than 10, then soda bicarb can be given. Magnesium sulfate, 4 ml of 50% magnesium can be used for the refractory ventricular fibrillation or digoxin toxicity patient. Anticoagulants and blood products can be used for the patients of DIC and blood product DIC, and if there is a hemorrhage. Treatment of cause hypovolemia, hypoxia, electrolyte imbalance, it should be corrected and treated simultaneously. It is important simultaneously during the CPR. Monitoring SpO2, cardiac monitor, capnography, then USG, echo, transesophageal echocardiography, BSL, coagulation profile, and temperature should be continuously monitored. This is the ultrasound guided decision strategy that you can see the normal heart when there is a, you can see the hypovolemia, so there is a collapse right ventricle and right ventricle. If there is a tamponade, the collapse right ventricle is there, fluid fill pericardium is there, and if there is a pulmonary embolism, collapse left ventricle can be seen and collapse left atrium. So it is useful to diagnose the cause of arrest and also the monitor the quality of the your CPR. Immediate post-operative care is essential and multidisciplinary team continues the care in the post-arrest period. If the patient is still pregnant, she should be placed in left lateral position and not in full lateral tilt. Manual LED should be maintained. The patient should be transferred to ICU unless an operation is required. Optimal pre-event planning should be ensured. This is CPR guide pregnancies. Fetal assessment during pregnancy, fetal monitor should be removed or detected as soon as possible to facilitate the PCMD without delay. Maternal resuscitation is the base fetal resuscitation. So fetal monitoring is not important during the CPR. Delivery, if the patient is full term and cervix is fully dilated, uh, then and head is an appropriately lower station, immediate assisted vaginal delivery can be considered during this resuscitation. This will allow the resuscitation of the fetus because and this emptying of the uterus will facilitate the resuscitation of the mother. Not every pregnant woman in cardiac arrest is a candidate for PCMD. The decision depends upon the whether gravid uterus is thought to interfere with the maternal hemodynamics. It was recommended that PCMD should begin at the 4 minutes to effect delivery at the 5 minutes after failed resuscitation effort because the survival of the fetus depend upon the time interval between the arrest and the delivery of the baby. So PCMD should be done at the site of arrest. Don't ship the patient to the theater or any other ICU or hospital. Facility of maternal resuscitation, early delivery decrease the risk of the neurological damage. The woman should not be transported to an operating room. Then the team should not wait for surgical equipment to begin the procedure. Only a scalpel is sufficient. The team should not spend time on antiseptic, pouring the antiseptic procedure and all that. Uh, Vertical midline incision, abdominal incision is taken because it is easy to deliver the baby. But uh, you can take you can take the incision as you are familiar with. Then it should be incision. The after incision, the baby should be delivered within the 5 minutes. Continuous manual LUD should be performed throughout the PMCD until the uterus is delivered. Care should be taken to avoid injury to the rescuer performing the manual LUD. If the
Sir, voice is gone. Avinash
आवाज
sir.
येत नाही, आवाज येत नाही.
Sir. Avinash sir.
सचिन, त्यांना अनम्यूट करायला सांग. अविनाश सर, अविनाश सर तुम्ही अनम्यूट करा.
हॅलो, येतोय आवाज?
हा, आता येतोय.
Okay. Sorry for this inconvenience. Then if left lateral tilt, call for resuscitation team. Then with oxygen and airway maintenance, CPR 30s to 2, apply ECG pad, attempt defibrillation if appropriate, if it is shockable. Then advanced life support, deliver baby within 5 minutes. If it is successful, advanced life support, stabilize the patient and deliver in ICU. Conclusion: the number of high-risk women undergoing pregnancy is on the rise, as is the rate of severe complication related to pregnancy, and so the cardiac arrest. Maternal cardiac arrest is a complex clinical scenario. Resuscitation of the pregnant woman involves multi-specialties and complex care decisions. Successful resuscitation of pregnant woman and survival of the fetus require prompt and excellent CPR. The newly developed in-hospital and out-of-hospital BLS ACLS algorithm should be the backbone of the response plan to maternal cardiac arrest. LUD of at least 15 degrees, placing the rescuer's hand 1 to 2 centimeters higher on the sternum to obtain better cardiac output with the compression is not recommended now. Consideration of immediate cesarean delivery in patient who has not responded after 4 to 5 minutes of ACLS. In addition, performing the cesarean delivery at the site of the cardiac arrest will likely improve maternal survival in both hospital and out of hospital setting. Life-saving interventions such as defibrillation and medication should not be withheld in the setting of pregnancy. Thank you. हॅलो हॅलो
सर.
हा, येतोय ना आवाज?
हो सर, येतोय.
हा, thank you very much. If there are any question, please.
सर, एकदम छान प्रेझेंटेशन झालं. आणि वन ऑफ द बेस्ट थिंग दॅट वी ऑलरेडी डिस्कस ऑन COLS every time, and everybody private forum person think that what is in that obstetric COLS. That we will do routine COLS in OBS patients, but you did one of the eye opener presentation that OBS patients COLS thing is different from normal than OBS patients. So one of the best presentations, sir. I want one question from my side, sir.
Please.
That you mentioned on LUD.
Yes.
LUD.
Left uterine displacement.
Yes, sir. You
Ah.
mentioned on LUD 15 or 30 degrees is not mandatory, that both are same, like that.
Yes. The
But,
clinical study shows that 50, there is no difference in outcome if you give 15-degree or 30-degree.
yes, sir. Sir, I want a question on other aspect. We are anesthetists. We are concerned on our drug. What we giving on OBS patients? Is it LOX? Is it bupivacaine? Is it ropivacaine or anything? Any even ISO. So LUD and these drugs. Any difference for CPR point of view or
No,
LUD point of view?
no. If the uterus is more than more than 20 weeks. Actually, LUDB is given if the uterus is size of more than 20 weeks. Some people give it to the also give to the
Sir, can I correct, sir? Can I correct my question?
uh,
Heavy and ISO. These two drugs are in emerging private forums nowadays.
लवकर आलो.
Yes, sir. So LUD and heavy drugs like LOX heavy, bupivacaine heavy, and isobaric drugs. What is the difference between them and LUD? Any suggestion from you to day to do practicing anesthetist? Use ISO or heavy and LUD percentage on that. Any uh,
I'm not getting your question.
okay, sir.
Left and is there any relation between the left uterine displacement and these drugs?
Yes, sir.
No, I'm not. I don't
Aware
know.
any studies, or you think
No.
isobaric is good for that? You don't need LUD in isobaric drugs. You need uh, LUD
No,
in heavy drug use like
it
LOX
is
and
not.
heavy
It is
bupivacaine.
not
If
related to drugs
any
only. It is not
or
related to these
difference
drugs.
between LOX heavy and bupivacaine heavy for LUD purpose, because most of the time newcomer gives LOX or gives heavy bupivacaine, whatever this setup said, भाई हमारे पास तो लॉक्स ही है, हमारे पास बुपिवाकेन ही है, and then newcomer try for that and elude and sudden drop in BP, he get frightened or that thing, and land up in the CPR status. So before that he should know that heavy or isobaric use or heavy, in between heavy LOX is bupivacaine is best. You should be really concerned on that for the
Actually,
newcomer peoples.
LUD is not related to any drug or any percentage of the drug. LUD is
Okay,
the
sir. Okay, sir.
only it relieves the aortocable compression.
Okay, sir.
It reduces the aortocable compression, and so there is an increase in the blood flow and hypotension. If there is a hypotension is corrected somehow.
Yes, sir. Yes, sir. Sir,
So therefore, it is not related to drugs.
okay, sir.
LUD is for to reduce the to relieve the aortocable compression,
Okay, sir.
because they had due to aortocable compression, the venous return is reduced, and
Sir, one
there is
question
a
from yes, sir. I interrupt for Tejas Bandari is our cardiac anesthesiologist from Nanded. He did almost 150 cases, almost more
uh,
than he's coming to 200 double century मारने वाला है cardiac anesthetist first cardiac anesthetist from Nanded. He's asking, sir, very nice presentation, sir. How about CPR issues in fixed cardiac output valvular disease like MS and AS?
hello,
हाँ sir.
so please repeat.
Should I repeat? Okay, sir.
Yes, yes.
Tejas Bandari, cardiac anesthesiologist from Nanded,
Question, question.
asking question. Sir, very nice presentation. Sir, how about CPR issues in fixed cardiac output valvular diseases like MS and AS, mitral stenosis and
Mitral and aortic stenosis.
yes, yes.
Mm, no specific alteration is or changes or modifications are given in literature for these specific what is the heart disease patient.
Yes, sir.
If he knows, please answer.
Okay. Tejas, are you online?
Yes, sir. No, I don't know. I also don't know any other thing other than what routine CPR has been done. But it
Hmm.
is very difficult to resuscitate six cardiac output state like AS or MS.
Okay,
Very
please
difficult
Yes.
on your
in spite
video.
of all our measures.
Yeah.
In
See
pregnancy,
results.
already there is
What?
a cardiac output
Yes.
issue.
Yeah. So you should use the vasopressors.
Okay.
Vasopressors like epinephrine, phenylephrine is also useful.
Okay. Sir, one more
For resuscitation.
raise hands by Dr. Rajesh Tagarpale, sir. He is a GC of our city branch. Sir,
Yes,
please,
Rajesh.
Rajesh, sir, please unmute yourself. Rajesh, sir. I think he has raised hand, but is not. Patange, sir, you have any question?
Hello, hello.
No,
It
Yes,
was
you
hello.
may.
muted.
Rajesh, sir speaking.
Yes.
Sir,
It was
please.
muted. Yeah. I think there is no difference between giving CPR in AS and MS. The problem is only with the outcome with that patient.
Okay.
There is no change in the procedure for CPR
Yes.
in normal cases and with the compromised cases, valvular heart diseases.
Hmm.
Only the difference in the outcome
So,
of the patient.
so you should use
Sometimes they
the
may deteriorate. The patient with the AS and MS, they will deteriorate and outcome will be different sometimes. But no change in the procedure or no change in the CPR
So you are
guidelines.
saying we need one more person from cardiac point of view in our CPR
Yeah.
scene.
And another thing you were asking for LUD. LUD
Yes.
is not at all related with any heavy or isobaric drugs.
that I have already answered.
Yes.
Yeah,
Hmm.
there will
Please
be
enlighten us,
no
sir. Please
difference.
enlighten. You are the very experienced person in Nanded also, and Avinash sir is also very much experienced, and he's exclusively obstetric anesthetist. So both are giving us suggestions. Is one of the best thing. It's a top of cherry. Please speak, sir.
I usually give pre-oxygenate the every obstetric patient. That means I suppose pre-oxygenation as a pre-medication
Okay, sir.
for every obstetric patient, even for the GA or patient coming for any small procedure like os tightening, MTP, or LACS. For every obstetric patient, I give pre-oxygenate the patient.
Okay, sir. Rajesh sir, your view?
Hello?
Sir. Your view, sir?
We do always oxygenation of all patients during the procedure. There is no,
Please on your video, sir.
I'm having dinner now.
Okay, sir. No, nothing problem. Sir, you said no issues related to drug, isobaric or hypobaric. Don't needed that LUD is needed every drug, whatever you give in anesthesia. Is this your point? I think so.
Yes, there is no difference. There is no relation with the heavy or isobaric drug with the LUD.
One more
You can
question.
give it in
I
any
want to
case.
ask both of you, Rajesh sir and Avinash sir. Is it related to what the radiologist and gynecologist says oligo. In oligo cases, really you need LUD and more drug. Any your experience?
Oligo, and there is no. That means you want to say that like polyhydramnios, the volume is more, so there is a more aortic cable compression, and in oligo the aortic cable compression is less due to less fluid.
Yes, sir. Yes, sir.
Is like that.
Yes, sir. Yes, sir. I'm pointing on that, and you are correct. You picking.
But giving it will not affect any volume for the volume of the drug.
Okay, sir.
We are giving the same drug.
Okay, sir.
Amount of the drug is same.
Same oligos or polyhydramnios.
Yeah.
Okay, sir. And related to LUD also, nothing to change in that scenario.
Because already even if there is a oligo or polyhydramnios, 1 fetus, 2 fetus, the pressure will rise. But
Okay.
pressure aortic wall compression is there if the there is a gravid uterus. It may be oligo, 1 fetus, 2 fetus. Only if the fetuses are 2, polyhydramnion is there, babies are large, then the compression will be more.
Okay. Rajesh sir, any comment on this?
Yes, I also think same as Avinash is saying.
Same, sir. Okay, sir. Thank you. Someshwar sir, it's your turn now. Please speak up.
Hello.
हाँ
आवाज
sir.
येतो?
Yes, yes. ये तो
Yes,
Sir, you mentioned there is no need of cricoid pressure.
yes. It is recommended. There is no need of cricoid pressure. It is given and it is recommended cricoid pressure. There is no use of cricoid pressure.
But
It
does
will
not
not
be related with the NBM status or what drugs you are using during anesthesia. It is not related with that. If the patient
No.
is not NBM, then we should think about the cricoid pressure, no?
No, a cricoid pressure is debatable in every time. This is debatable. Due to cricoid pressure, there is a difficulty during the airway management or intubation.
Okay. Very
It
nice
is-
presentation. Today there is some technical hiccups. आज
Yes,
काय झालं आज
Sir.
खूप लोकांना जॉईन होता नाही आलं.
नाही सर
पण
बेसिकली
काय
काय मोस्टली आय थिंक हॅकिंग part is happening all over the world due to the Ukraine Russia or something like that. Today
Because I
only
tried
problem
3
happens.
times,
Nothing
then I
till
left.
now. Up till now nothing happened in our platform. Everybody is easy to share their screen also, and everybody can join from all over India. But this is the first time I have to add by email. Just now I SMS to technical people. They said they will clear in next meet.
Okay. Because that's why so many people are in the waiting side.
Yes,
And
yes.
I joined after my 3rd attempt.
Basically, we are started at 8 o'clock. Na? These people are blocked after 8:10. So many people join. But after 8:10, they are saying this is late, something late coming in.
Okay.
Avinash sir, very good presentation. Nice to see you after
Thank
so
you.
many days.
बघू जरा.
तुम्ही राजेश सर पण ऑन करा ना व्हिडिओ. तेजस सर, सतीश, प्रल्हाद सर, our president Kotkar sir also is on. Really? Yes. This is a live.
माझा व्हिडिओ चालणार
Something.
माझा व्हिडिओ चालणार
Yes,
आला
yes.
रे सचिन.
Satish, you also come. Please on your video.
Rajesh.
Yes, hi, Avinash.
One of the lovable secretary from ISA Maharashtra. because he is almost touchable to our hearts because of his thoughts and his working, because he did almost a lot of donation of blood, COLS, many programs he attended, and he did that. He's really admirable person from our ISA Maharashtra. Prahlad Kotkar,
Yes, I do agree with Sachin.
really,
I
really.
know I know Avinash from last 20 years. He is a well organizer. He has organized one state level conference at
Conference and
Mahabaleshwar. Yeah, I attended that one and it was nice arrangement. He's a very active secretary we got
Yes, sir.
and we are proud of him.
Our all
thank you.
secretaries, Hitendra Mayan sir is also extraordinary person. This Avinash Bhosale sir is a runner, one of the best person. He do running a lot, and I'm inspiring on that. After my fracture also in सर तुम्हाला सांगू इच्छितो की मी लास्ट मिसॉकॉनचा ट्रेजर होतो. That time my leg was fractured. That so that I cannot meet all peoples, but I also active in that. आणि तुम्ही खरंच
Okay, thank you for the
तुमच्यामुळे मी रनिंग सुरू केली आता.
होय का?
रनिंग सुरू केली. मला बरेच जण म्हणतात अरे पळू नको बाबा, थांब जरा शांत हो. इतक्या गडबड करू नको.
नाही कॉम्पिटिशन नाही करायचं, पडायचं हळूहळू.
हा जस्ट येस सर. कोटकर सर
ओके
प्लीज
चलो, thank you, sir.
चला थँक्यू.
सर really I'm appreciating your work, आणि one of the best person from by heart. You are really genuine person. आणि आज तुम्ही स्वतःहून आज ISA प्लॅटफॉर्म वर आलात, and you say that of last case meet was related to ops, and you said that our topic is next is ours, and that thing is one of the person, because I'm conducting case meets regularly. You are the first person who come forward and told me that I am taking next case meet. I'm really happy, sir, from ISA Nanded and ISA all officials also. They are everybody is happy on that.
Okay, thank you for the comments, and thank you very much.
Chalo, thank you.
We'll meet again.
Yes, thank you. Okay.